Hello, my name is Rudy Nunez. I am a Pharmacist Candidate class of 2024, and today we'll be presenting on Risendronate. Its brand name is ACTONEL. As an introduction, I wanted to give a brief overview of Risendronate. Risendronate belongs to the bisphosphonate derivative class. Its dosage forms include oral tablets in strengths of 5, 30, 150, and then delayed release 35 milligram tablets. Its primary use is going to be for osteoporosis. It is currently first line agent for osteoporosis. It could also be used for Pagetis disease, which is a bone disease, and then for prostate cancer. Its mechanism of action is to inhibit bone resorption via actions on osteoclasts. For its pharmacokinetics, we're going to discuss them in terms of the ADME processes. For absorption, we know that it has a fraction of a bioavailability of 1%, which is relatively small. We will counsel that the patient has to take it 30 to 60 minutes prior to a meal because food can impair its absorption. It is known to have a rapid absorption with poor bioavailability. Its volume of distribution is 13.8 liters, and it can be 24% protein bound. There is no evidence that there is systemic metabolism of Risendronate at this time, so it's not metabolized as far as we know. And its elimination is going to be primarily through renal elimination. It's 50% renally eliminated and has a relatively large half-life of 561 hours. And its clearance can decrease by 70% with the creatinine clearance of 30 milliliters per minute or less. In terms of indication, we have three main indications that we will be using Risendronate for. The first one is osteoporosis in male and in postmenopausal females. We could also use it for Pagetis disease of bone treatment, and we could also use it in patients who have prostate cancer to prevent bone loss associated with androgen deprivation therapy. For osteoporosis, we typically can start with immediate release, oral tablets 5 milligrams once daily, or we could do the 150 milligrams once monthly. And we could also use a delayed release tablets 35 milligrams once weekly. For Pagetis disease, our initial treatment is going to be the immediate release tablets, the 30 milligrams once daily for 2 months, and retreatment within the next 5 years can be another course of 35 milligrams once daily for 2 months. For patients with prostate cancer, typically we are going to recommend oral tablets, the 35 milligrams once weekly delayed release tablets. In terms of osteoporosis, its pathophysiology is relatively, it can be complex, but in simple terms, we're going to see a decrease in bone density. So here in the images, we have a healthy spine, and we have a healthy bone density on the left side, and on the right side, we have a lower bone density seen in the images and increased risk of compression fractures and fractures of other types of bones. Here in this image, we see the spine with osteoporosis, and it's starting to compress and it's starting to become more complicated for the patient. In the next two slides, we will discuss some of the different pathophysiologies that are associated with osteoporosis and with bone disorders. So in a typical healthy bone, we're going to have a bone homeostasis in which bone is constantly being recycled. The old bone is being replaced by new bone. And we have a homeostasis between bone formation and bone resorption. Bone formation is held by osteoblast, and it's building up the bones and creating new bones. And osteoclasts are breaking down bone. And this process also helps supplement our serum calcium levels. So in a patient with osteoporosis, a good counseling point would be to recommend that they supplement by exogenous calcium and vitamin D to help supplement their bones as well. But when you have a patient who has osteoporosis, we have bone formation is much less than bone resorption, so which means that osteoclast is either overactive or we have osteoblast underactive. Whichever the case, with Risendronate, we're going to be targeting osteoclast and trying to inhibit its osteoclast for breakdown of the bone. On this slide, we're going to talk about Pagetis disease, and Pagetis disease is a chronic bone condition in which the body's normal recycling process is disrupted. similar to osteoporosis, but in this case, bones become enlarged and malformed. Usually the pelvis, spine, skull, and legs are affected in Pagetis disease. And here we have images of both normal bone and then pagetic bone. And you see the bowing of and the hypertrophy of the bone in Pagetis disease. It also says thickening of the cortical bone and fracture increase or fracture risk increase. We also have increased vascularity and fibrotic tissue in the bone marrow. And you just start seeing in the skeleton picture where the femur is starting to become more and more deformed. In terms of its mechanism of action, ACTONEL at the cellular level inhibits osteoclasts and osteoclast precursors. This ultimately then results in a decrease in the rate of bone resorption and increasing bone mineral density. In Pagetis disease, ACTONEL can indirectly decrease bone formation and slows down bone hypertrophy, leading to more normal bone formation and bone architecture. In terms of warnings and precautions, we do have the warning of bone, joint, and muscle pain. This is infrequent but severe, and it can occasionally be debilitating for patients who do report having bone, joint, and or muscle pain. We're going to just stop bisphosphonate treatment. It has been reported to range from between 1 day of the onset of treatment to several months after starting treatment. For disease-related concerns, patients who have had bariatric surgery have altered absorption and also have an increased risk of ulceration, and so we're going to avoid use in these types of populations. For patients who have glucocorticoid-induced osteoporosis, we're going to evaluate sex steroid hormonal status prior to treatment initiation. In patients with renal impairment, we're going to use with caution. We are not going to recommend it in patients with a creatinine clearance of less than 30 milliliters per minute. And we currently do not have any type of approval for pediatric patients. In this slide, we're going to talk about some of the adverse reactions that can happen in a patient who has taken ACTONEL. And here, this table is listed based on frequency. So first, we'll talk about the more common, and it happens in more than 10% of patients: rash, abdominal pain, constipation, nausea, diarrhea, indigestion, backache, and urinary tract infections. We could also see in the less common, in 1 to 10% of patients, asthenia, flu-like symptoms, edema, arrhythmias, nephrolithiasis, myalgias, and bone pain. But in more rare but serious and less than 1% of patients, we could see osteonecrosis of the jaw and hypersensitivity reactions. Also noted below this table, we have hypocalcemia. Because we are inhibiting osteoclasts and the breakdown of bone, we are also going to see a reduction in calcium being released into the bloodstream. So hypocalcemia can happen there. We could also see thigh bone fractures, and this happens because when we're also inhibiting the breakdown of bone and letting bone build up stronger, we're also making it less flexible and more at risk of having a thigh or large bone fracture. We also can see esophageal irritation, and here we're going to just note that this could be avoided if we counsel our patient to, when they take this medication, take on an empty stomach, but also don't lay down. You're going to want the patient to stay upright for at least 30 minutes and to not eat for 30 to 60 minutes after that. Some of the monitoring parameters in terms of efficacy, we're going to see an increase in bone mineral density. Again, prior to determining a diagnosis for the osteoporosis, we're going to have a DEXA scan and we're going to have a bone mineral density analysis. And here we're also, with efficacy monitoring, we're going to see the bone mineral density increasing and getting better after using ACTONEL. We could also look at a decreased incidence of fractures over time and normalization of alkaline phosphate in patients with Pagetis disease. In terms of toxicity monitoring, we are going to assess the baseline serum creatinine, the calcium, and assess for skin rash, chest pain, difficulty swallowing, especially when we have esophageal irritation or swelling, tooth problems, pain with urination for UTIs potentially, and severe pain just in general as well. On this slide, we're going to talk about some of the drug-drug interactions that are typical in a patient when they're taking ACTONEL. And so some of the typical agents that can interact are aluminum or calcium-containing products. And so they can decrease bisphosphonate absorption. We are going to be told to separate administration by 1 to 2 hours. For H2 blockers and PPIs, for histamine antagonists and proton pump inhibitors, we're going to see a decrease in bisphosphonate absorption as well. And so we're going to consider therapy modification. We're going to try to avoid it if possible, and especially if we're using the delayed release formulations of Risendronate, we're going to avoid this combination. With aminoglycosides, we see an enhanced hypocalcemia effect with the Risendronate, so we're going to monitor therapy. And with NSAIDs, non-steroidal anti-inflammatory drugs, we can see an enhanced risk of GI ulceration and nephrotoxicity. So once again, we're going to monitor therapy. Some of the key counseling points for a patient who is starting on Risendronate therapy: we're going to counsel the patient to take it as soon as they wake up in the morning before having anything to eat or drink. We're going to also tell the patient to take it with a full glass of water, to swallow the tablets whole, and this has to be swallowed with water, not mineral water, not coffee, not juice. We're also going to tell the patient to wait 30 minutes after swallowing the tablet before you eat or drink anything or any other types of medication. We're going to tell the patient to not lie down for at least 30 minutes after taking this medication. Again, we're trying to avoid that esophageal irritation and erosion there. We're going to tell the patient to not lie down until they've eaten something as well. We're going to recommend adequate calcium and vitamin D intake. We're going to tell the patient to limit alcohol and tobacco use. And we're going to also tell the patient, as just a lifestyle intervention, to perform regular weight-bearing exercises that can help increase with balance and the prognosis of the patient's condition. Listed here are some of the clinical pros that are going to be your take-home points from this presentation on Risendronate or ACTONEL. And so its clinical uses include osteoporosis, people with Pagetis disease, and in patients with prostate cancer. A medication guide is required at dispensing. Altivia is a brand name for the extended release formulation of Risendronate, and so we're going to recommend that patients and providers know that it's not interchangeable. It's always going to be taken first thing in the morning. We just discussed this in the last slide, but it's a very important counseling point. It's first thing in the morning. We're going to take it with a full glass of water. We're going to tell the patient to stay upright and to not eat anything for the next 30 to 60 minutes. Concurrent therapy with chemotherapy, IV administration, and poor oral hygiene can increase the risk of one of the more severe side effects, osteonecrosis of the jaw, and atypical fractures of the thigh have also been reported in patients taking bisphosphonates for osteoporosis, and discontinuation therapy is then recommended if this happens, especially if it's evidence of femoral shaft fractures. And listed here are my references. I want to thank you all for your time and attention in this drug information presentation. Thank you.